So, as we said, this is just a presentation about the tips and how the exam goes, because when I prepared for it, it was a bit vague. So what we'll cover today is the exam format, what are the pass marks, tips on how to prepare, which books do you need to go through, do you really need to enroll in any courses, and what do you need to bring with you on the day of the exam, and some exam day tips. So these are the things that I couldn't find written in any book. Um, couldn't be found easily in one course. It just needs someone who's done the exam that's willing to sit in and organize all these tiny things. Because, for example, the things we need to bring with us on the day of the exam, we panicked just suddenly a month before it, like, oh, what do I need? Can I get this, or do I need this, and so on. So the exam format, you have 2 days, one day for the Viva, which has 5 stations. And you'll also have the communication skills, which is part of the OSCE. You'll have it on the same day. So on the day you're going to your Viva, you're going into 6 stations total. The stations of the Viva are a bit long, so one case, and you're going to discuss it with the examiners in 10 minutes. They're going to have some questions for you, and we'll go through also how many questions they have. The names of these sessions are: first one, investigations and data interpretation. You have 2, patient management, and then 1 for attitudes, ethics, and responsibilities. The last one is audit research, evidence-based practice, health promotion, disease prevention. The number 4 and 5 are what I call the theoretical a bit, because they need a lot of reading from the blue book, and we'll go into that in a few minutes. You'll have 2 examiners in either the Viva or the OSCE anyway, and the total of the Viva marks is 120 marks. If we go to the OSCE, you will have it's supposed to be 6 stations because it has the communication skills, but we've moved it to the Viva, as we said. So you're going into total 5 stations. Each one of them will be 20 minutes. So total of 5 stations, 20 minutes. That's a bit of a longer than the Viva day. In these 20 minutes, you're going to have 3 patients or 3 cases. That can be patients, 1 patient, 2 videos, 2 patient, 1 video, and so on. They divided the curriculum into anterior segment, glaucoma and lead, posterior segment, strab and orbit, and then neuro. And then, as we said, the communication skills is going to be happening in the Viva day. Mix of patients and videos now, so it really depends on the day of the exam and how they manage to find patients, and are the patients willing to sit there through the whole day or not. So it's a bit of a hit and miss. So you need to be preparing for both scenarios, having all patients or having all videos. The total marks of the OSCE are 198 marks. So as you can see, the OSCE has a higher value or higher weight in your exam. So you can do shit in the Viva, sorry, but you can still pass the whole exam if you did really, really well in the OSCE and it balanced a bit. Of course, if you really failed all your stations, that's gonna be a fail. But I mean, like, if you didn't feel that you did your best in the Viva, and especially because the Viva is usually the first day, or the first exam you'll have will be the Viva, and then within a day or 2 you're going to have your OSCE. So sometimes you will feel like, oh, it's done, I'm not gonna revise for the OSCE, it doesn't matter. But no, actually the OSCE carries the higher marks. And from what I've seen, you can really prepare better for the OSCE, and you can really maybe get even full marks in the OSCE if you want, just by focusing on certain things that we're going to talk about. So if we also see how is the weight of each station, the Viva, each station has 24 marks. So if we go here, each station has 4 sections, which means 4 questions. So if we're having a long case, the examiners will be already having 4 questions to ask you, or like, for example, what is your differential, and what are the investigations you want to order, and then how would you manage, and then are you aware of any landmark trials, or even as in my case, the fourth question can be a different case. Like in my exam, one of the patient managements was unilateral ptosis, and then they keep giving you question, but the fourth question was, fine, the patient's wife came in with bilateral ptosis, and she wears contact lenses. What's your top differential? So it can be even like a tiny scenario. So, but you're gonna have 4 questions. Why is that important to know? It's important also to keep your morale high, because if you looked at the history that they gave you and you have absolutely no idea what is a diagnosis or what's happening, do not panic. They will try and help you, but at the end they might tell you, let's assume this patient's diagnosis is Horner, and then they're going to ask you a question. So you already got maybe 0 or 1 in that first question, but you still have the rest to go and get marks from it. They might ask you a simpler question later on and you get marks from it. So if they shift the question, shift your mind. Do not focus on shit, I should have said so, or I should have said that. No, just focus on the next question, the next case, the next day, and so on. The OSCE has, as we said, 3 patients or 3 cases. And each patient or each case has 2 sections. So 2 questions on the same case. So they might get you in, and there's a patient inside, and they tell you, please examine the anterior segment of the right eye. No history, nothing. So you go on, you examine, and we'll tell you a bit of tips about also how to manage that. And then you should be very quick about, okay, I'm looking at that, this is the findings, the important negatives as well. And then if you reach the finding that they know, they might stop you and then just go ahead, okay, what's your differential for this finding? Okay, how are you going to manage? And then quickly it just runs off. And if you're saying the correct buzzwords and the correct words they want to hear, quickly you shift to the next case, and so on. But if you keep hesitating or saying a lot of negative findings without saying the positive ones, you'll be losing time and it might affect your later cases. As you look here, the 2 sections are examination. This is the first part that they will give you marks on, so how you've done it, and did you reach the findings or not. And then the second one will mostly be diagnosis and management. There can be a bit of tiny questions under the management, like, okay, what are the complications of this treatment? But they all fall into these 2 sections. So one station, so for example, if you don't know anything about neuro and you're doing the best you can to study and you've managed to do the best you can in all the other stations, this one station has 18 marks from the whole. If we look at the pass marks, you need about 75 marks in that's approximate. So this is from the April exam, what they published. The pass mark was 75 from 120, and in the OSCE was 125 over 198. And if you can see, there are some people who get very high scores, and I don't know how they do it. But anyways, just a few points about the communication skills section, because this one, they kind of gave us the exact questions or the exact things you are being marked for. So they are 6 points, and you have 2 examiners. You need to establish report and information gathering, which is the introduction. Hi, my name is so and so, and can I confirm your name and date of birth? Are you all right? And then you start. So that's establishing the report and gathering the information. Can I understand why you're here today? And so on. And then the development of more information gathering depending on what the patient says, point on information delivery, and then understanding of information giving, that you're aware of the whole thing, appropriateness of advice and accuracy of information. So it might be a case that you don't know anything about the guidelines, but you're trying to be vague and tell your patient, all right, we're going to manage you the best we can, and you're not giving the correct medical advice. this is only 1 point from the whole station. So also so if you panic about the topic, do not panic, just calm yourself down, because there are other things that you can do right and gather marks from. And then there is a point from the patient, so they mark you also on your overall communication skills. This is a very busy slide, but what I want you to focus in is that this red dotted line is the pass mark. So if you can see, there are many people who can pass the exam, and that can definitely be you. So the percentage of overall pass rate for the exam was almost 75% of people. So and I think it doesn't really reflect the knowledge of the other 25%. It just reflects how well you could control your nerves, how well you can shift your focus from the past station and just focusing on the next station and so on. So this is for the Viva, a lot of people have passed. This is for the OSCE, a lot of people have passed. So the majority passed. And this is what I want you to focus on, because when I was preparing for the exam, I felt like it was a bit of an impossible one, but actually the numbers doesn't say so. So you can definitely do it. What do I mean by theoretical stations when I'm going to talk? This is a screenshot from the main book that I'll tell you, which everyone calls the blue book. This is a screenshot just from the, the titles of the chapters. So you have these two chapters that they look so much alike, and you feel like you're reading something, but you're not gathering any information from it. However, they can actually ask about them, and there are two stations in the exam on them, and I think you can really ace them and take the whole marks in your pocket, so that even if the patient management stations, the two clinical stations, you didn't do well in them, or they came in the subspecialty that you didn't practice enough, you can still save your whole Viva by acing these two. And the only way you can really memorize these two chapters is by having a study buddy and reading them together and just trying to stick it as much as you can in your brain. The other thing that it was a bit of a personal experience of me, but I think it's still a valid advice, is to not start studying these ones. So start with your clinical, gather a study group, do all of that, and then maybe start reading these 6 weeks before the exam, because they are really volatile and you really forget them just so quickly after you read them. So do not waste a lot of time far away from the exam, and then you forget them, and then you read them again and you feel like it's the first time, and so on. So tips to prepare. The first and the most important is group study is not a waste of time at all to this exam. It is actually the way to pass. So you cannot depend on studying alone as for the previous exams. You will not be able to pass, because each one of us has a bit of a tie tongue, as you say. So your tongue is not very fluent in the things that you do not practice every day. And I'm sure none of us is practicing all the subspecialties all day long. So you need to be practicing out loud. You cannot study and say, okay, I have it in my mind organized. You need to say it out loud. So group study is the most important thing you can achieve by even attending one of these sessions and looking at the participants and sending each other messages. Are you free to practice this Friday? Are you free to practice? And so on. 1 hour a day will yield better outcome than 7 hours in the weekend. It is very hard, nearly impossible to practice every day. But if you make it a goal, you may be able to practice 3 days a week. But if you say, I'll only practice on the weekend, you might miss a weekend, and then it will be a whole 2 weeks passed without studying. You need to activate energy saving mood at work. So I know that we always aim to finish audits, do research, participate in many things, go out in the department outing, but you really need to be saving your energy to when you go home and study. So try to be using work for your benefit. So every day at work is a practice session. So you go home and you study this part, or you say, I'm going to always confirm the patient's name and date of birth and confirm this and try to build a nice report, try to smile more to the patients, try to be more empathetic so you can ace your communication skills station, for example, sorry. So what you need to do with your group study, you need to practice the OSCE station. How you can do that is that you need to get an image or a video, and I'll tell you where to get videos from. Each is 5 minutes. So you need to be practicing how to be systematic, organized, quick, and being able to say all the buzzwords in 5 minutes. So I can show you a picture of facial palsy. You know everything about facial palsy. You've seen so many patients in eye casualty, or you've already studied it 100 times before. But what you need to practice is saying it, or saying the most important things in 5 minutes, without startling, without hesitating, without forgetting, without focusing on one point and leaving the others. So this is what you need to be practicing on. And I remember the first time I was saying the example of facial palsy because the first time I had a group study and someone showed a picture of facial palsy, and I said, okay, I'm going to do it. And the time ran out and I didn't say everything I know. So I didn't have a gap in knowledge at all, but I didn't practice well enough to be able to squeeze all my information in 5 minutes. So that's what you need to do to practice the OSCE. To practice the Viva, you need to also get an image or video, but you need to be able to talk about it in 10 minutes. So these will be like the really common thing that have common diseases that have some depths in them. Like, for example, diabetic retinopathy or diabetic macular edema or keratoconus, any of the things that have a lot of depth or a lot of things that they can really talk with you for 10 minutes about them. And also that's what you need to practice with your group. Practicing communication skills need you to be 3 people at least, one being the candidate, one being the patient, and one being the examiner. And the thing is, you need to be prepared to whatever scenario they get you. So, for example, in our exam, there was a day that they had a very weird thing. So their station was you are talking with one of the secretaries or one of the admin team because your clinic is always overbooked, and because of the backlog or whatever, they need to even overbook it more, and you now need to talk to your secretary or your admin team to explain how this is hard, or this is difficult, or this will affect the patient safety and so on. So I don't know how they got to marking this station, but keeping your cool nerves and remembering the 6 things we talked about here, like whoever is going to be the patient or an admin team or whatever, I'm going to establish rapport. I'm going to say, hi, how are you? If they are an admin team, you can fake like you know them. So, oh, you told me you went out with your family last weekend. How did it go? Just anything, and the person in front of you will just go on with it. Information delivery. So I've heard that we're going to be overbooking the clinic. Yeah, have you heard that as well? So you're building report, you're gathering information, and then you will talk, oh, but that will affect patient safety, or that will do that and that. So whatever the station, as long as you know the points you're being, assessed on, you can still do it. Even if you miss 1 or 2 points, you can still get the others and you can still pass. The guidelines, you need to teach it to each other. So because there are so many guidelines out there, if you have a group, each one of you will be doing a certain subspecialty, and they'll be able to really squeeze in the guideline into just few sentences and tell it to you in a way that you can really remember it. But if you get all the guidelines and read them all together, they will just mix up in your head. And as I was saying, the theoretical chapters, try to read them together so you can come up with maybe some mnemonics. So for example, in my exam, they said, what are the principles of the Data Protection Act? So if you read it in the book, you'll find that each sentence repeats the sentence before it. It's like doesn't make any sense or can be really, you know, summarized into 1 or 2 points, but you need to say the whole lot of them. So we did a mnemonic with my group study, and I actually remembered the mnemonic and I was able to answer it. So I'm hoping that you guys can really use the theoretical chapters to put marks in your pocket just in case that the clinical cases are difficult for any reason. The other thing is that this exam is different because you need to know how to answer more than what you're going to answer. So we're going to talk about frames and how you need to answer in a certain way that even if you don't know what the real treatment is, you can still get some marks just by saying a frame. I want you to also practice the common cases till you're able to talk about them without thinking. So a case like Horner, a case like diabetic macular edema, you need to practice them a lot. So if you're sitting in your group study and you practice them once, it's not enough. You shouldn't say, oh, it's fine, we've passed them, let's go into the rare ones. No, keep practicing the common ones. Always have a priority for the common ones because common is common and they're going to come. The things that we always kind of never focused on in our previous exams are the things like the occupation of the patient, smoking in their social history, driving, certificate of visual impairment, the FSRs of ECLO, the low vision aid clinic, the PALS, all of these things. You don't really have time or have questions on them in your previous exams, but they have a huge weight in the oral exam. So they should be really, really on the top of your head in each station. Whatever the station you're in, say, I'm also going to ask about the occupation and smoking in the social history, and ask the patient about driving. And if it's the patient that has, you know, advanced glaucoma or any of these things, I'll also send the patient to low vision aid clinic and the ECLO and make sure they have a certificate of visual impairment. And these things have very high weight in your marking. So as I was saying, your answer should follow the same frame, so it becomes a habit because the frame makes them think you're a safe doctor. So, for example, this is a frame that I used to practice me and my friends. So in every Viva station, they will give you like a 22-year-old male presented with decreased vision, and then they stop talking. What are you going to do? So you keep saying everything. So sorry, this point was supposed to be in the beginning. So in the history, I'll take personal history, complete and thorough history of the current complaint, especially focusing on how it started, so and so associated symptoms, does he have double vision? So it depends on the complaint of the patient. Add other symptoms that you're going to ask about that seem fitting to ask about. So if it's, does they have flashes and flutters? Is it in one eye or both eyes? Did they notice anything with it, and so on? And then as well as past history of medical conditions. And if you feel like this is a station that's going into keratoconus, for example, you can say in systemic associations if appropriate, or if they were found in the medical conditions. I'll also ask about the patient-specific concerns and expectations, and inquire about social history, including occupation, driving, and presence of family support at home. So the more you say this paragraph, the more you say this sentence, it only takes like 3 or 4 seconds because you're saying it fast and you're not thinking about it. You're just saying it as a song that plays on. And as you're saying it, you're giving yourself some time to think about what you're going to say about in the real answer of the question. But they will mark you. There is a mark on saying all of these things, but saying them quickly and saying them in a focused way. And then I also had these 3 points in any Viva. So they would, for example, say, okay, what do you want to examine in this patient? You would think that, oh, it's atosis, so maybe I will just say the lead measurements. No, you need to say everything that you do for your patient in clinic. But I know because we sit in eye casualty and the patient comes in already having their visual acuity done, their IOP, their pupil, they already have all of these done. but you need to say them. You need to remember that they need to be done before the patient comes to you. And then according to the I also added ocular motility as well for each eye. And if I am in an OSCE station of a glaucoma, I would say visual field and so on. And don't forget orthoptic assessment, because sometimes we just drop it from our mind. But if you know that these items are already in the things you're going to say, and you'll see if they're appropriate to be said or not. So, for example, oh, the patient is coming in complaining of flashes of flutters. Then you're going to skip the orthoptic assessment and you're not going to say it, but you know that it's a point to be said. Don't forget saying, I'll examine the other eye, especially in the OSCE, because they might tell you, examine the right cornea of this patient, and then you examine and then you say all the findings and everything. But your diagnosis would never be full until you know how the other eye looks like, because it can differentiate between a decompensated cornea from, for example, post-phaco, or it's decompensated because it has FRCOphth and the other eye has FRCOphth as well. And then you will say, I'll do a thorough anterior and posterior segment examination. And then you can go on with whatever they want you to say next. But these are very tiny. They look big on this slide, but they take a second or two to say, and they collect marks. So we were saying that you need to talk in frames. So this is how you need to say every answer. And I know that it sounds a bit stupid, so I wasn't convinced of it in the beginning, but everyone has advised me to do it. To have a frame of saying, if someone asks you about the management in OSCE, for example, some people would say this one, number 2, I'll treat the cause, treat the condition, treat the complications. And the most common frame used is the conservative medical surgical. And this is the one I've used, although it seems like the most basic one, but I've found that in most courses they've said say it. And most consultants that I've met, they said say it. So even if you know that this is a patient that's going to be taken to surgery because, for example, it's a ruptured globe, you're still going to say in the treatment there is conservative medical surgical. In conservative, of course, the main treatment is surgery, but I'll be taking care of the patient pain. I'll see if they need any antiemetics, and I'll make sure they have they are NPO before the surgery, and if they have any comorbidities, to make sure that they are under control, diabetes or hypertension. So because you've said the word conservative, you'll be starting to think of what to fill in it. And the things that you're filling will turn out to be important things that they want you to say so they can mark you on it. So I would say use it. It seems a bit annoying in the beginning, but use it in every practice. Every case, when you reach the management point, you say conservative medical surgical, and then you dive into each one of them. And the moment from my experience, the moment they hear me say conservative medical surgical, they seem relieved of it, and I don't know why. Like they haven't heard anything from me yet, but they seemed relieved of it. So this is the one I'm picking. Another frames that my group study did, for example, to make it easier for us to be saying things, even if we're thinking in the back of our mind of something else. So, for example, we said that if we have any abnormality in ocular motility, the differential would always include myasthenia gravis, thyroid eye disease, and one with the letter D. If it's horizontal, it's Duane. If it's vertical, it's co-deviation or DVD. So if you have any disturbance in ocular motility in horizontally, and you're thinking, oh, what could it be? It could be this. So you're focusing on one differential, or you're focusing that this is definitely a slipped muscle, but they will be waiting for you to still say other differential. Even if it's so obvious that it is one diagnosis, you still need to fill up the answer of differential. So you need some things to be able to fill it quickly. So myasthenia gravis and thyroid eye disease can cause any type of ocular motility. So any case you're going to say them in, you're never going to be wrong, and it will give you an extra second to think of something else. But be a bit, thoughtful. So you're still a doctor. So if it's a third nerve, then this frame is not the exact right way to go. So if it's third nerve and it looks like a third nerve and it walks like a third nerve, quacks like a third nerve, so you need to act like it is a third nerve because it's a life-threatening condition and you need to act like it. So they need to see you concerned and talking about it as a diagnosis that you have in your hand and you're going to investigate. And it's not like sitting around thinking, oh, maybe it's myasthenia, we'll send to the myasthenia gravis clinic. So you need to say the aneurysm as your first differential diagnosis because we need the urgent CTA or MRA to exclude posterior communicating artery aneurysm. So if the case in front of you is a life-threatening or sight-threatening, you need to say them first. But if it's just a normal case, then all these frames are going to help you very much. And they're going to, as I said, give you a few seconds to think if you having difficulty remembering something or so on. The other thing, the other advice I was given is that you always need also to highlight your differential, especially if they tell you examine the optic nerve of this patient and then you examine or they show you a video of an optic nerve that is pale. So you have optic nerve pallor, whatever, and they tell you go. Like there is no other information. So you need to be able to say everything, but still seem organized. So you need to have any type of frame for your differential for these very big and wide topics. So there is Vindicate, for example, or whichever you like. There's vitamin D and there are others. You can use this, you can use others, but you tell them that we're going to be working through a surgical sieve, V for vascular, so it may be from a non-arthritic ischemic optic neuropathy, inflammatory, it could be post, optic neuritis from MS or from an infection, neoplastic, it could be so and so. And so the moment they hear you going through a surgical sieve, they know that you'll be able to fill it in and you'll get the mark. So a way to say your answer in a very attractive way to the examiner that gives you marks is after you finish the video or finish examination, you say, so to summarize my findings. So while you're examining, they'll tell you to talk while you're doing it. So you'll think that you've already said everything, and then you look at them and say, okay, I finished the examination. There will be like a moment of awkward silence because they will be waiting for you to summarize it. So to summarize my findings, for example, this patient has alternating exotropia with bilateral normal abduction. This is also a way to say it in the exam. You need to say abduction. So they don't say you've said the wrong thing. Abduction, but bilateral impaired adduction with no nystagmus. So this is an isolated abduction deficit. So for example, you give a title to the case. So my top differential diagnosis for this case, because of the history or whatever, is bilateral slit medial rectus muscles. But other differentials include Webino, but there would be abducting nystagmus, or bilateral medial wall fracture, but there would be significant history of trauma. Other causes of abnormal ocular motility also include myasthenia gravis, thyroid, and Duane. So if you go through it like this, you will be already covering the points in their answer sheet, and you'll be already collecting the highest marks because you summarize the findings, you've put a title to your case, you gave the most probable diagnosis, and you gave other differential while explaining why they are not your top ones. Because, for example, as I say, here there is no trauma, or here there is no nystagmus. And then you would also add some other differential that will be, that can work in your case. So this is how you should be able to say your answer, especially in the Viva. So you need to prepare for the videos. So I've looked around so many websites and links and YouTube channels, and I think these three are the best ones to use because they are not they don't have the perfect quality, and in the exam it's not a perfect quality, and they are very, short, and it's the same way in the exam, so they really imitate the exam. And I know you cannot take the links from here, so I'll send you just a feedback form, a tiny one, and once you fill it, you'll get a link for a Google Drive that have all these links and other things useful as well. So there's a Sharjeel I YouTube channel, which actually most of the consultants use in their teaching. They are sometimes in the exam itself as well, and there are two other channels. So you go to these channels and you just pick a video and you show it to your colleague in your study group, and then you put the timer, whether 5 minutes or 10 minutes, according to which you're practicing on a day, and then go. For examination techniques, there is a very nice recorded session from Mustafa Doudar. He's also doing a course. So he ran through this book. So you'll find that we say yellow book, which is for this book, and a blue book, which is for that book. So the yellow book has the examination techniques just put in points. So it really gives you a scheme to work on. And I think the session that Mustafa did was really, really good. And I think he's going to do it again as well before the next exam. For the past two times, he's done it for free. So even if you're not in his course, I think you can attend, but I'm not sure if it's the same this year or not. And I'll also give you the link. By the way, there is no, financial disclosure for anything. I'm just saying what worked for me. So this session is on YouTube, free to watch, and I think it was really helpful. And it will tell you what you need to be doing to do the examination the right way that they want. So which books to go through? This book, the blue book, as they say. So despite not being perfectly organized and not having the most updated information, it is still the book that you'll be able to pass the exam after you read it, because it is done just by the way of the exam, just how the exam is, by the chapters, by the stations. So it is really a must to go through it from A to Z, all of it. You need to go through it. I did go through it, and I would go back to Oxford Handbook because I've studied from it before for the written. So if there is something that you have a very good visual memory for, keep studying it from here, but see how this book has written it, because this book will be telling you about the irrational other differential diagnosis that they'll be waiting to hear. Even though it looks like a diabetic macular edema, it is diabetic macular edema. It's nothing else. They will be waiting to hear other things, even if they don't seem logical to you. The DVLA I'm putting here because it is a must. It is a big issue in the exam. Viva, OSCE, even theoretical stations. It may pop up in every station even. It's very, very important. And then the examination technique. The other thing is the NICE guidelines. So how can you know what is the updated NICE guidelines? So for example, there is one that is published on the 13th of August. See how recent it is. So this is the link for it. I'll also put it, but if you want to go to find it yourself, you just go to the NICE, you go to NICE guidance, and then you go to picking the conditions and diseases, you pick eye conditions, and then it will give you all the guidelines just, sorted by date. So the most updated will be up here, and then you can read it thoroughly, because usually they try to get a question from the most updated NICE guideline to make sure that you're reading it. So the million-dollar question, do I need to attend any courses? What do you guys think? If you can just type in the chat, are you already enrolled in any courses? Do you feel they're helping you, or are you still waiting for for guidance on which course to join and so on. Just write in the chat. I think that, where is the chat? So, yes. No, I think that's previously. Yeah, so people are attending courses. So, as I was saying, it's the $1 million question if you should attend or not. The most famous ones on the market now are these three. I would say the positives and negatives, and it depends on each person what they prefer and how they like to study. So London Eye course is very expensive, but the thing is, it's a package with its mock exam, and the mock exam can be face to face. So if there is a very good merit or a very good advantage for the London Eye course, it is the face to face exam. If you have any other courses around you that can do a face-to-face exam, then it is more important to attend more than the London Eye course. But the positive about the London Eye course is that it runs through, I think, 3 or 4 days, and it's a full day. The morning is a subspecialty, and then the afternoon is a subspecialty. You have one of the best consultants of that subspecialty giving you 3.5 hours of many, many cases, asking you the questions and telling you the answer they want to hear. So it's like a private course for ophthalmology in general as well. And it was really helpful in terms of knowing what is the most updated thing, what do consultants in this subspecialty think? Do they like saying this answer first or this answer first, or how do they want us to say it? So that's a very good advantage. The only disadvantage, I think, is it's always held about 6 weeks before the exam, and it seems like a tiny bit of time. Because if you found out that you've studied that subspecialty in a very different way, or you're missing a lot of things, you don't have that much time to gather all the information. However, because it is very intense and full of information, you might be able to answer something from the exam just by the memory of that course. But it's really, really expensive. And I think I'm not sure if Liverpool or Manchester are doing some courses like this one, but because I was doing my exam in London, I was focused on having a course in London, because the face-to-face exam, as I said, they got patients in, so you got to really be in the mood of the exams, see the patients. The patients might not be that cooperative, so you're under all that stress. So it was helpful from that point. The Oxford Eye course is done over a weekend, so it's 2 days. The sessions are like half an hour each or so, like multiple, but like half an hour, 45 minutes, and so on. And you have the author of Kansky with you, Jack Solomon, there talking in the course. So that's a good person to meet and listen to. They also give you a very, very good way to answer to the exam. So if you've studied very well, but you want to see how you can put all your knowledge into the right way of answering, Oxford Eye course did that. It was really, really to the point, getting the most important cases, telling you what the buzzwords are. And Imran, who's the one responsible for the course, is very, very nice, very cooperative, and he had very, very nice notes. I'll be sharing one of like one copy or one screenshot from one of his notes to see how he can really provide you with good things. And then we have Mustafa's course, Revise and Conquer, and this is its link. The good thing, or the really good advantage about Mustafa's course, is that it really helps us guys who need a push to study. So he gives a session every week. So even if you have a lot of things on your plate, or you're doing many things, or you're on call or whatever, you still have a session, a regular session every week that is based on a whole exam. So he's giving you a full mock exam for everyone who's attending and giving each of you the opportunity to answer on that slide or on that station. So you get to hear a lot of people answering as well, and that gives you an idea of what you can do better and what you're missing or what you're even good at. If you listen to someone and think, oh, but I think I'm better in this subspecialty because I have a very good differential in my mind, or wow, look at this person, how they answered the question. I feel like I want to memorize every word they said. So it's really good because he forms a community before the exam. You're having a session every week, a very comprehensive one. So the amount of topics and the amount of images and videos we're going to cover in that course will be much, much more than any other. And I think it's, looking at the amount of information he's giving, it's really not that expensive. And I think he's also offering now mock exams, but I think everything is on the website. I don't have any relationship with any of these courses, but I've attended all of them, and that's why I'm giving you my opinion or about the advantages and disadvantages. Of course, it's just my personal opinion, but that's my opinion if you're thinking of enrolling. So just to revise what I said, see what you would benefit more from. So if you're like, no, I want something with a mock exam, or no, I want someone to be with me every week so I can cover everything. So you'll know which course to go through. Now, this is the slide of what to bring with you to the exam. So all of these things you need to have with you. So get a transparent, what's it called? The word is out of my mind now. You get, yes, a pencil case. So yeah, thank you. So you get a transparent case, and it needs to be transparent. So pick a good one, and then you'll be able to use it at home for any other thing. You need at least 2 rulers because you'll need to sometimes measure proptosis and all of that. You don't need to have an exophthalmometer with you. You need the torch of the NHS, or because that one that you always find in the NHS is not very bright, so it doesn't annoy the patients, so they're not annoyed and they are cooperative in your examination. If you have one of the LED ones or the very bright ones, then maybe put any porous sticker on it, or like anything porous over it, just to decrease the intensity of the light. Why am I saying 2? It's because one station was very, very dark, and that's in the mock exam that I attended. The room was dark, and the patient had very, very dark iris, and the examiner was telling me do a full neurological examination. So I needed to see the pupil. So I couldn't see in the dark. So what I did is that I put one torch just, right in front of the patient's chest, aiming at their eyes, so that their face is in the light, and I give his eyes a few seconds to adapt to get back to being wide. And then I told the patient to look at a far object, and then I used the other torch to do the pupil examination, and I was able to detect a relative afferent pupillary defect this way. But if I didn't have that second torch to light the patient's face, I wouldn't have been able to see the pupil because he had very, very dark iris. And then you need to have a fixation target. So what I did is I actually got like a sticker and put it on one of my rulers. You don't need to have that many things. Some people have, if they attended a pediatric rotation, they have the funny things for the children, but you're never going to have a child in the exam anyway. So it's just any fixation target. But the thing is, the fixation target needs to have something you can ask. So for example, what is this child holding? So what I had is like, it's I think it was a star, and then I would ask, what is that shape, or what is the color of the star? So something that you can ask so they can be really focused or fixating on it. You need your lens that you use on the slit lamp. You don't need to get a 20D or 22D or so on for the indirect. They provide that one. They also, in my exam, provided the lenses for the slit lamp examination, but I really think if you're used to your own, then it's better to have it, definitely. The red and white pin, especially for the visual field examination, I was lucky that I didn't need to use it in my exam, but others need to use it, of course. So the red to use for the blind spot. And then an occluder. So you need to have your own occluder with you. I have bought that one because it allows you to really see or diagnose the DVD, the dissociated vertical deviation, when you see that the other eye went up and then there is no motion in the other eye and so on. But of course you can have any occluder, but I think this one gave me a bit of confidence that at least one disease I'll be able to diagnose easily. So these are the things that you need to have with you. Any other thing you don't need to. A 20 diopter lens for indirect, you don't need to. A direct ophthalmoscope, you don't need to. Any other thing that's not on this slide, you don't need to have it. So now we're on the exam day. So just the things right before the exam, I would say book the closest hotel room to the venue of the exam. How would you know that? Because they don't share the venue up until very late. And I want you to notice that at least there will be 100 candidates or more. There was 140 something in my exam in London. So what I did is that I asked where was the exam the last time it was held in London, where was it? And I knew it was in the Royal College of GPs. So I just booked a hotel very, very close to it with free cancellation. And then when the venue was marked, I already had booked my hotel with a very cheap price. Because once the exam venue is announced, everything is booked and everything is very expensive. Because why you need to book the closest? Because you need to avoid multiple changes in your journey. So we had a candidate in our exam that got stuck in the train. So her whole day was gone because she got stuck, and she was calling everyone and saying, "I'm sorry, there was like a defect happened, or like something happened in the train, and they need to move to the other train," and so on. So you cannot afford to be stressed about a train or a train strike or your Uber canceling on you or any of these things. Try to minimize the things that are out of your control, so you can minimize your being nervous, the chance of being nervous. I want you to keep a list while you're studying. You need to keep a list of like only 5 things or even less than 5 things that you read on the night of the exam. So you'll go to your hotel the day before your exam to sleep there. That's the best thing you can do. Or if you have your car and you know where you're going to park, you would still be aiming to go to your exam very, very early to avoid any, car accidents on the road and road delays and all of that. So if you can really stay beside the exam venue, you're saving yourself a lot of trouble. So anyways, back to the night of the exam, you need only like 5 things that you are unable to memorize. You've done your best, but every time you read them, you forget them. 2 of these 5 things will be the DVLA and CVI. So these 2 things you're also always going to forget. I will put on the Google Drive the link that I'll send you. I will put the DVLA, but I've edited the main file to kind of remove everything that's not eye related and keep only the eye related things because it's a huge file. It might help you, so I'll put it there. And then the CVI, who will be sight impaired and who will be severely sight impaired. All these things you forget about. So these 2 things you need to revise at the night of the exam. Please dress smart. So do not try to make any fashion statement on the day of the exam. So I had a friend who gave me an advice of saying, I want the examiners to not remember what you wore the moment you go out of the door. So you need to just be only recognized by your answers, just in case they are not examining you again in the OSCE and that you did, very poorly in the Viva or whatever, or or the examiners will talk about you later on, so they will recognize you, and then the ones in the OSCE will say, oh, that's the one that answered so and so in the Viva. You don't want that. You don't want anyone to remember you. Just, they assessing you about that station, and that's it. So don't make a fashion statement. Keep your nerves as much as you can. Tell yourself this is just another eye casualty session. I can deal with most, if not all of the cases that comes my way. It's just like it, and you don't need any in-depth knowledge, especially in the OSCE. Everything is like an eye casualty session. It's very quick. They just need you to know that you know the important things, the life-threatening ones, you know your way to the investigations, and you know your way to the at least the basic management, like, oh, the patient will be managed by the oculoplastic team in the end, or whatever. Don't forget to be nice with the patients, and that's very, very important, because I know they tell the patients do not say anything, but I'm sure that the patients say things. So there was a station when I went out, I don't know, their voice was a bit loud, so I could hear that the patient was telling them, oh, this girl is so nice, please give her a nice mark. I'm sure they wouldn't give me a nice mark just because he said that, but it will definitely, affect their opinion of you. And there was a patient even that somehow he saw me when we were going out of the building, and he came and said, hey, doctor, you're the one who saw me today. You were one of the candidates. I remember your name. You said your name was Esra. You're a very nice doctor. Where do you work? I want to come and see you. And I said, I don't work in any private thing. So, but that's how being nice to the patient is really important. And remember, most of them have been coming to all the exams. Like they know that there's an exam coming, and they keep calling them, because some of them have like certain diseases and that, or a very good finding. So they're always in the same exams. So they have seen nice people before you. So if you're not maintaining the same standard of being nice and appropriate, that will be a very, very bad thing, because if they say the negative comment, the examiner should take it into consideration, because if you annoy the patient, or if you hit the patient's nose with a slit lamp, or if you treated them in a bad way, that says a lot of things, and they can write that in the comment about you. So please remember, being nice to the patient will really save you a lot. So when you go into the station, oh, hello, hi, and you say hi to the patient as well, even though you're supposed to talk to the examiner in the beginning. And then you ask the patient, can I please examine you? I'll just shine a bit of light into your eye. Are you all right? Although you know that everyone before you have done that, still tell them what you're going to do and explain it in details and take their consent. Remember that each station is separate, each question is separate. So if you didn't reach a diagnosis, the mark for the diagnosis is gone, but the mark for the investigation is not gone, the mark for the management is not gone, the mark for the other questions is not gone, and the mark for the other patients is not gone. So, and that's what I told my mind. So I remember that they got us a very weird, confusing HES chart in one of the stations, because it seemed like it wasn't under action, but they drew an arrow above it, like you do with the overaction. So it was like, why is there an arrow here when it's an under action? So I was a bit confused, and I really got scared, and somehow my mind went blank, and I couldn't really analyze the HES chart properly, and I forgot the most basic things I used to say in my practice. And then they prompted me. So they said, okay, this patient has so and so. How are you going to manage further? So I've taken it from there and answered the investigations, answered the treatment correctly, and I've seen in the feedback when they sent it to me that yes, I lost the mark. I didn't lose it completely. They gave me one from the diagnosis, but they gave me good marks in the ones below it. So please just focus that whatever the question is, if they shift it to the next one, then you shift with them. So as I was saying, in OSCE, if you totally messed up a whole case, you even didn't say a word, you kept your mouth shut through the whole case, you still have 2 other cases, and you still have the rest of the stations to cover you in your OSCE. You always use the frame you practice. So if you go to the exam and you find some people revising before it and they say, oh, I always put my differential in that certain way. Do not use it. Do not listen it. Use the one that you've been practicing and that is a part of your subconscious now. The other good advice is read the name of the station and focus on it. So that's a very, very, very important thing because there are some diseases that can appear in two stations, but the buzzwords are different. So if you have pseudoexfoliation management in a glaucoma station, the buzzwords are so much different than if it comes in the anterior segment. In the anterior segment, they're going to want to know about the cataract and the consent of the cataract and the cornea and all of that. In the glaucoma, they want to know about the glaucoma management itself. So read the name of the station, like really, really look at it and say, now I'm going into the glaucoma and lead. Any question they ask me, it needs to have the buzzwords of the glaucoma and lead. Then let's say they ask you something and you don't know. You should never say, I don't know, because this is an exam that qualifies you to be a consultant. And when a consultant doesn't know something, he still knows the approach on how to deal with it. So you don't know if this, for example, mass is a melanoma or is an avus or whatever it is, you don't know. You say, I'm going to do these investigations. I'm going to do an ultrasound and I'm going to do an OCT on it. And I'm going to refer it to my colleagues in medical retina or in so and so, or in ocular oncology. So you still need to be able to know the approach. So you never say, I don't know. So if they tell you, okay, now this is atosis due to a certain disease you never heard of, what are you going to do? So I'm going to manage conservative medical surgical. So conservative, I'm going to see the patient's concerns and expectations and see what they want. Is it affecting their occupation? Is it so and so? How about driving? How about that and that? Medical, I don't think there is a medical for the ptosis, but I would see if they have any dry eye, if they have any other annoying symptom that they want to be treated. And then surgical, I'll see if I can correct the diagnosis, but I will take the opinion of other consultants because I would say that I don't have the enough expertise to deal with this syndrome, for example. So that's you being a consultant who knows how to deal with something they doesn't know, a part of them saying, I don't know. The other thing is listen to the instruction and question carefully and do only what they ask. So if they tell you, please examine the posterior segment of this patient's right eye, you go in and you just focus, just see, okay, the patient is sort of phakic or something very clear, but do not focus on examining the anterior segment because they want you to focus on the posterior segment. You go there and then you keep looking and you say, okay, there is this and there is that, and my top differential is that this is a microvascular retinopathy, but I'll need to examine the other eye and take a thorough history to see if this is diabetic or not, or hypertensive or any other cause. So what if you're a bit confused? They give you a question that you don't know, or they tell you examine the cornea of the right eye only, and you examine and you see that there is, decompensation, corneal edema. You can say, these are my findings. Can I proceed to examine the other eye? And they would tell you yes, or they would tell you, no, the other eye's fine, or the other eye has the same signs, and then you will go on with the questions. So listen to what they are asking you because they always focus on this point. In the exam, adjust the slit lamp or the indirect or the direct or whatever you're going to use right away. So keep on looking at adjusting the slit lamp, the light of it, the power of the eye lenses and all of that before the time goes on, because that's, if there's a problem, you can say right away. So I remember a candidate before said that the indirect, the light of it got broken or whatever, it was not working. So he was putting it and he was like fussing with all the things and it was not working, and he was trying and it's not working. And they told him, but a bit of time has already passed. So they told him, okay, fine, what is your differential if you're finding this finding? But there is a bit of a long time that has passed that could have been in his favor if he said it earlier. And be very systematic in your examination. So study one examination each day and make sure you go and examine it on your patients in your clinic to have a very smooth technique. Talk while you're examining to save time, and also because if you reach the desired finding, they might stop you. I thought that this is a very basic thing, but actually in my mock exam, I found that I didn't say anything because that's what I do in clinic. I just examine. And then the examiner said, can you please tell me the findings while you're examining, not at the end? So I know it sounds a bit basic, but if you're not used to focusing on saying it, you might miss it in the heat of the exam. And if they ask you to check again, please do. So don't tell them, oh no, I'm sure there's nothing else in the posterior segment. If they say that, they're not trying to trick you or anything. You will be missing something. So that's all the tips and tricks for the exam. If there's any questions about what I've said up till now, I'm glad to hear any. I've been talking a lot without hearing any of you guys.
Hi, Isra. This is Samreen here.
Hi, Samreen.
Thank you so much for preparing this for us, and I can see you've put in a lot of effort into it. I think this is one
Oh,
of the
thank
best
you.
sessions I've attended for in
Oh,
order to
bless you.
prepare me for the exam. Very good.
Oh,
Excellent.
thank you. Thank you so much, Lorraine. I really hope it's helpful. And
It is.
as
It
I
is.
said, it's just the tips, but there is a case that we can do. It's a Viva case as a practice. I can stop the recording if you guys like, and then we can just do that
Y-
Viva case.
Yeah, yeah, why not?
Yeah?
Yes.
Okay. Okay. So let's just stop the recording.